let's hear a little bit from Dr. Allan in terms of what his experience has been with regard to COVID, and if it's been any different, and if you have any helpful suggestions or recommendations for us.
Absolutely. So obviously, yeah, this is a very evolving time that we live in now, and I think we have to prepare and expect that, you know, COVID is here to stay. It's not going anywhere anytime soon. And essentially, you know, we have to prepare for that expectation for our patients. And so, you know, I think my experience is, obviously this is a devastating disease. This is something that we do not want our patients to get. You know, we do know there's emerging data, heme patients, cancer patients in general and therapy are at higher risk for poor outcomes. We know that our patient population, being older in general, has already one of the major risk factors for severe complications from the disease. And so we really have to do our best to protect them. And one is encouraging just social distancing, the masks and the hand hygiene, and really reiterate that. And we know from healthcare workers that if you practice these, you know, very basic things, you can decrease your infectious rate. So I think that's important to get out to our patients as well as to our physicians. I think that's more recognized in our system. I think with our CLL patients, I have found when we are in this exponential phase, this is not a time when you want to be initiating treatment on a patient for all these factors that Dr. Shadman had spoken to about minimizing interaction, the immunosuppressive effects of some of these treatments. And essentially, you know, if you do have a watch and wait patient, that's where you push them out to telemedicine and, you know, minimize labs, getting local labs where they can be scheduled, and kind of avoiding public transport. Obviously, if you have a very sick patient and they need to initiate treatment, you do have to make some decisions, obviously. But I think that's also where it comes in, and the fortunate opportunity to have many options. You know, BTK inhibitors are a great option for a patient that needs to get out of trouble. You can start a drug. Sometimes it gets mailed and delivered to them, and essentially they can start the drug, and they have low toxicities, and you can do video visits with them and kind of even, you know, see how they're feeling, get local labs 2 weeks or a month later. And that's a great way to get somebody out of trouble that needs treatment in that situation. A VEN-G based approach where you need to ramp up, and there's obinutuzumab and anti-CD20 and frequent hospitalization visits, probably not ideal. And so I think it's region specific. What I've found now, where New York has gotten back to kind of normal, you know, we have low infection rates, we have low daily admission rates. I think in New York State, we only had about 30 total hospital admissions in the last day or so. And we are, if you look at our curve, we are, you know, maybe total a couple hundred new coronavirus diagnoses a day. And so at this point, we are in a window of opportunity that we can really kind of, at least in New York, go back to our previous thinking and reasoning for specific patients. And at this point in time, if there is a good patient that's eligible for a VEN-G based approach, I'm not so scared at this point in time to do that. Though I think it's going to be region specific. If you're in a state or a city where you're seeing kind of increasing, like we are seeing in some of our states currently, where you're seeing kind of increasing and even exponential phase, we don't know where that's going to bottom out. And I can say that we're at high risk for having serious issues in some of those places where that's a spot where you don't want to be initiating treatment. But I think, you know, there's a lot of things. It's all region specific, it's patient specific. If you can wait until you're kind of on a downswing and the situation is better controlled, it's best to do that. Obviously, if you are in a situation where you need treatment and you are in a place where there's increasing cases of this disease, having discussions with your doctor, maybe a BTK approach is probably like a little bit easier and you know, more likely indicated. You know, we don't have any evidence right now that patients with anti-CD20 therapy or specific treatments have worse outcomes or have more severe outcomes. I can tell you from just personal experience, a handful of patients, I've had patients get sick that have had anti-CD20. They've gotten over it and took a little time to clear, but then finally have developed antibodies and have cleared the disease. This is while being on BTK inhibitor plus an anti-CD20. The anti-CD20 was several months prior and was done. They had severe complications, but they had other risk factors, hypertension, renal insufficiency, and some of these things that we get concerned about. I've had other patients that have been on just a BTK inhibitor. They're in their 70s, relatively healthy, get the disease, but have very mild, minimal symptoms. I've had other patients on watch and wait, have very mild, minimal symptoms. I've had people on watch and wait get hospitalized, but not ventilated. And then I've had many patients with CLL, just properly doing infection control, social distancing, not even get the disease. So I do want to reiterate to patients and other physicians out there that, you know, it's not, you know, just because a CLL patient's going to get sick, that they're going to have horrible outcomes, though they are at risk for those things. And I think that over time, we're going to start to understand what types of treatments may put them at risk. But in reality, I think what we've shown time and time again from just coronavirus patient data is that really what we're seeing is age, hypertension, kidney disease, diabetes, obesity, pulmonary disease. These are the things that really come together in a perfect storm, this inflammatory basal state that the patient has that then gets tipped over. And it's really patients are dying from this inflammatory overwhelming condition that occurs with this virus that we haven't really seen before, and we're still trying to grapple with and understand. So complicated answer to a tough question there. But I think really what the important take home point is, watch your region, watch the state you're in. And if you are in one of these places where it's not well controlled and an exponential kind of taking off phase, you got to be careful and really think about your approach. Whereas if you've kind of gotten it behind us, I'm starting to tell my patients that it's safer to re-engage with society. And I'm now starting to think that my previous reasoning for pre-COVID, if I thought that patient was a VenG patient, I'm comfortable at doing this. I feel like there's a window of opportunity, though that could change literally in 3 months if we start to see a second wave. And so you have to just pay attention to your caseload and where the virus is regional specific.
And I would agree. My thought has been that our patients are in tune to social distancing already, even before COVID, and they do good hand hygiene, and that may have reduced their risk. But we haven't here seen that CLL, a diagnosis of CLL, puts patients at an increased risk, more so than any other factor that we already know about. Has that been your experience, John?
Yeah, I mean, I definitely think, you know, our patients are immunosuppressed at baseline. And, you know, I think when we've seen our numbers and kind of look at some of our data, and I know there'll be data emerging with larger cohorts coming out, I'm sure, by ASH and other in the near future. You know, I think we do see probably more serious complications in this patient population than what we would do for just kind of all patients. But I think, again, that also represents our patient population. They're typically older, they have underlying CLL. And so I think some of that is based in some of those risk factors inherently. But I do think that they are at a greater risk for complications. So with that said, it's not everybody, it's not the majority, and most patients can be okay. Some, a minority don't have major problems. There's a middle ground that has, you know, they get hospitalized, but they're not on a ventilator and all these types of things. And then there is that other quarter to maybe a third or whatever it is that we see in our own practice and in our own ICUs that have had very serious complications. Some have survived, others have passed away, but it is something that I agree that our patients are at higher risk for severe complications.